Good afternoon, Professor Myatt. This is Cody and Sam's presentation on our nurse anesthetist. Want to go for it, Sam? Let's do it.
Sure.
All right, let's do it. All right. This is our introduction slide. So this is the main reason why we decided to choose this topic. It is a very high demand field. There is a very high demand of a degree of autonomy. It has a very lengthy history. It goes back to the BCE era, and there's very interesting pathophysiology that goes with it. For me, I find it very interesting to where you can put somebody in such a deep sleep, a deep coma, and they're still unable to feel that they're having a limb amputated or that they're having a part of them removed. They don't remember it or anything. So that's what turned me on to this. Thought it was really interesting. CRNA versus anesthesiologist. They both use the same equipment. One goes to school a little bit longer than the other, but we'll get into that later. I found a really cool little quote that I would like to share with you, and it said, "When anesthesia is administered by a nurse anesthetist, it is recognized as the practice of nursing, but when it is administered by a nurse or an anesthesiologist, rather, it is recognized as a practice of medicine." Regardless of the educational background, nursing or medicine, all anesthesia professionals give anesthesia the same way. So I just thought that was really interesting. Let's see. Go to the next slide. So what is a CRNA? So CRNAs work in collaboration with surgeons, anesthesiologists, dentists, podiatrists, and other qualified healthcare professionals. They take care of patients' anesthesia needs before, during, and after surgery. So you will see them every once in a while. They will come in, like I know at my hospital downtown, we will have a nurse anesthetist come and see the patient, and we will have an anesthesiologist. It just depends on who is going to be on schedule for that day, but somebody from each member will come and see the patient, and it really calms the patient and lets them know that everything's going to be okay whenever they go down to surgery. So the CRNAs, they perform the physical assessment. They participate in the preoperative teaching with the patient. They perform and prepare the anesthetic management, administer anesthesia to keep the patient pain-free during surgery. They maintain the anesthesia intraoperatively using these equipments right here. Let me switch back. These little machines right here. They oversee the recovery in the PACU post-operatively, and they follow the patient throughout the course of recovery from the PACU to back to the floor to wherever it is that they came from. Let's go to the next slide. They are dedicated to ensuring safe, cost-effective anesthesia care while administering to the patient's physical and emotional needs and offering reassurance and comfort. I thought this was very interesting. The word anesthesia, it was coined by Oliver Wendell Holmes in 1809 to 1894. But of course, anesthesia history goes back many, many, many centuries before then. The Greeks got it from the word without and refer to it as an inhibition of sensation. A little bit about the CRNA history. CRNAs have been providing care in the United States for more than 150 years. The CRNA accreditation was first recognized in 1956. They safely administer 43 million anesthetics to patients each year in the United States, according to the American Association of Nurse Anesthetists. Let's see here, next slide. Some of the early medicines used in anesthesia were carbon dioxide used in the 1820s, and then we used ether by the 1930s. Of course, we have discovered since then that these are very poisonous to the body in large amounts. A little bit. And we have since moved on to bigger and better things. Let's see here. Opium, first anesthetics used. It had recorded use in Lower Mesopotamia all the way to 300 BCE. It was referred to as the plant of joy because of its numbing and hallucinogenic effects. Also, cannabis incense were in India and China prior to opium produced to those countries, and early anesthetics proved to be toxic and hazardous to life. Okay. The Florida Nurses Act was to ensure that every nurse practicing in the state of Florida meets a minimum requirement for safe practice. A nurse falls below the minimum competency or otherwise presents a danger to the public, prohibited from practicing. This is why we're all licensed. CNAs, CRNAs, RNs, all of us. We have to maintain a certain location, continuing credits every year to be able to do what we do to keep patients safe. There are many requirements I have learned just in nursing school. And the biggest one is passing the NCLEX. You plan on going on to your bachelor's of nursing, you pass your NCLEX, bachelor's of nursing, and for nurse anesthetist, you have to have a master's in anesthesia. Most colleges, from what I've read and experienced, you're going to need 2 years experience in an adult pediatric neonatal ICU, or C, which is a critical care unit, which is what both work. Let me see if I can get this. There we go. Emergency room, operating room, anesthesia, and obstetrics are not listed as a care.
I was surprised by the obstetrics.
I was too. I mean, obstetrics is really. I was too.
Children. You're constantly monitoring.
The reason that these diseases are not rated ICCU is because contact with the pathophysiology from a day-to-day basis. They're not in control of these monitors on a day-to-day basis. And the units really need to know your stuff in order to you can think tense and anticipate something that might happen, opposed to the emergency where you only need to 2 or 3 steps ahead of the person. Staying certified, board of certification, the C program, they require that you have a minimum continuing education over 4 years. It's 100 credit hours every 4 years, so you need 200 credits in an 8-year period in order to stay certified. By that 8-year period, you have to take a certification exam. So complete rules are required 4 years as well in 4 contexts: airway management tech, applied pharmacology, human physiology, and anesthesia equipment technology. How to work machines, because they change every single new stuff.
All right. So, Association for Nurses, the American Association, that's logo and their website. Okay, so CRNAs do have standards of one of their standards is to provide you recovery from an actual assessment are required to provide transport of the patient to the facility. Also respond to the care until report is given to them at the PACU. Then they're also in charge of the monitoring evaluation in the PACU and continuous clinical options. Only the provider can authorize the discharge of the patient. And then the quality and improved post-anesthesia care is always changing. So it looks good news job growth RNA. Because of the nursing shortage, they are expected to have a 31% growth over the decade. So that was actually a height of growth in the other throughout the United States. So nursing outcomes, there is a difference between patient care between a CRNA physician, anesthesiologist, or supervised physician. CRNAs only provide effective quality, whether they're sized or not. It's just the name of our profession. Currently, nurse for care and med services care payments to an ambulance CRNAs care absent physician supervision. However, since 2001, the Center of Medicare and Services non-state opt out at Medicare seats in states. Most recently, California in 2009 opted out. Now we have our service versus our value barriers. So this is that we now is for care reform in general with launches and political points with care. So our bundled value-based care is which specific individuals has to call their own from the whole the care of the patient actually advised as a versus individual fee-for-service that's provided. Kind of healthcare professionals in general account for versus individuals that was leads to reimbursement increase which strain on patient considering more capping ratio. This is safe for my economic fee for some of the cons are that they tend to pay later extra because extras bring revenue, which helps out more along all of the turns over throughout daily versus your time you regard of patient's care to that income. So cost providers revenue. But with the bundle care, you have that hourly or that out. So you motive to take them if your money doesn't bring the facility the owner of your work. So they're done won't over what I myself and care if I can in that shift versus money turning over me for service. Then evidence-based practice and two Association of Nurses director of require the breakers and create a high-pressure process would ensure whenever a related dose is created or revised. Our is not ever changing today. Things new versus before.
That's all we need constant credits in order to certify, because we have things change single year.
Unfortunately, had their practice. Our physicians that have a block of independence in a practice. CAs are not medically trained as well as the so they don't do duties. Study on that, not the issue. To provide outcomes are saying RNA to great care to all patients in the outcome. Pressured sonars for Medicare, a physician revision for the at this regulation requires CRNAs to be and the long going to healthcare money can have full versus amount of money only over CRNA this outcome. The OES stays in full revision medical training, saying that they have training and our CRNA preventive of our system with a good job